Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Managing scleroderma can feel like trying to make sense of innumerable disconnected data points. Well, with the power of statistics and high-throughput computing, perhaps that is all about to change. The manuscript we will discuss today is development of a personalized visualization and analysis tool to improve clinical care in complex multi-system diseases with application to scleroderma. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures is available in today's show notes. I'm delighted to be joined by the first author of this manuscript, Dr. Soo Kim. Dr. Kim is an assistant professor at the Johns Hopkins School of Medicine with a joint appointment in biostatistics at the Johns Hopkins School of Public Health. Her research focuses on developing statistical methodology, including efficient estimation of patient trajectories in high-dimensional settings to effectively model personalized interventions. To translate these methods into clinical settings, Dr. Kim has developed an interactive data visualization tool to illustrate patients' disease state and clinical trajectory and to define individualized risk predictions for major complications. Her recent work includes studying the complex relationships of the immune response in cancer and identifying latent subgroups of patients who share similar multivariate pulmonary function trajectories. The work Dr. Kim will discuss today focuses on scleroderma, but she's also extending this analytic framework to other rheumatic diseases, including psoriatic arthritis, myositis, vasculitis, and Sjogren's disease, in which biomarker trajectories also play a critical role in clinical decision-making. Welcome to the show, Soo.
Thank you, Dr. Shamagam. I'm very excited to be here and share my research today.
Oh, and you can definitely call me Vicky. So tell us a little bit about the background to this work. How did you get involved in scleroderma research?
Yeah, so when I was a PhD student in biostatistics, I was supervised by Dr. Scott Seeger, and he's a pioneer in building statistical methods to analyze repeated longitudinal measures. And he introduced me to my mentor, Dr. Ami Shah, and she introduced me to the world of rheumatology. And then I was amazed by the heterogeneity in patients' disease trajectories in multiple organ systems and also treatment responses in scleroderma. And I felt like this is a field where modeling the disease course over time could really help doctors and patients make better decision making in the clinic. So that's how I got involved in the scleroderma research.
You definitely had some of the best mentors right there. So tell us a little bit more about why you wanted to develop this visualization and analysis tool.
Sure. The idea came from observing how much information physicians have to synthesize when they're in the clinic and caring for patients with complex rheumatic diseases like scleroderma. So, in a typical clinical visit, clinicians mentally integrate data across multiple organ systems, looking at how a patient has changed over time, considering baseline risk factors, and really trying to estimate things like disease progression, risk of complications, or whether aggressive therapies may be needed. And this could be a very time consuming and cognitively demanding process, especially in a rare disease where there's a lot of clinical variability from one patient to another. They usually have detailed information about patients sitting in front of them, but they don't really have tools to allow them to learn from patterns observed in similar patients. And also, it's not always easy to communicate these complex longitudinal medical information clearly to patients and their families during a routine clinical visit, especially when decisions involve uncertainty or high risk treatments. So, our goal was to develop methods that could help organize and visualize these complex data in a more intuitive and clinically meaningful way. And our hope was that these kinds of tools could eventually support both clinical decision making and patient centered communication across many chronic diseases.
Yeah, I mean, it's so thoughtful and forward-looking that you did this. So you built this tool using something called our Shiny app. What is Shiny, and how did you deploy it in this particular instance?
Yeah, so R Shiny is an R package used to build interactive web application directly from an R code. So we built a prototype version of the visualization and analysis tool because it could generate an interactive website with a single R script without requiring web development skills, which I don't have. And this prototype enabled fast iterations and revisions for our team before embedding the app into our electronic medical record system.
Yeah, it's really clever, and I'm so glad that you were able to do this. So to develop the app, you used longitudinal data that was already available in the Hopkins Scleroderma Research Registry. Can you share with us who is enrolled in that registry and how is the data collected from those patients?
Sure. So we utilize clinical data from over 4,000 patients from our research registry. It's a dynamic entry prospective longitudinal cohort that includes all consenting patients who meet either 1980 or 2013 ACR criteria for scleroderma, had at least 3 of 5 features of the Crest syndrome, or have definite Raynaud's phenomenon, have normal nail fold capillaries, and a scleroderma specific autoantibody. So, data from the registry participants are ingested into the Johns Hopkins University Precision Medicine Analytics Platform, or PMAP, where all of these multiple data sources are harmonized. So, Johns Hopkins Medicine uses Epic as an EMR, and this captures all data coming from clinical care, including clinical visits, lab measurements, prescriptions, imaging, and procedures. And this real time Epic data from PMAP is used in our visualization and analysis tool.
Yeah, I want to go a little bit deeper into that because it's not just lab data, it's really all clinical outcome data, including patient reported outcomes, things like pulmonary function tests, echocardiograms, skin scores, lung imaging, everything that we collect during routine clinical care. So, this data is not only time varying, but of course, our patients are on different medication regimes. And most statisticians would just look at this and throw up their hands, thinking that the rheumatologists are somewhat chaotic. But you were not put off. How did you handle the variability within this data?
Yeah, so because it was so challenging to harness longitudinal data from multiple data sources, it actually became a big motivation for our team to start building the prototype version. This whole project started when our rheumatologist described how much time it takes them to collect relevant data to assess a patient's disease state in the clinic. So our goal was to have a working app where clinicians can easily assess patients' disease course over time and share that with patients as they talk through the care recommendations together. And I'm not going to lie, developing this web based version of the app was a very heavy lift, and it required a collective effort of clinicians, statisticians, software engineers, and user design experts and human factor engineers.
Yeah. How long did it take from first idea to first iteration?
So the idea started when I was a PhD student, which was a long time ago. Developing the Shiny app itself took me about like a year or two, but actually embedding it into the Epic EMR, that was a very heavy lift. And I think it took us about a couple more years to actually make it usable. Yeah.
Yeah, I'm sure some of that was managing hospital complexity and getting the various people who are in charge of EMRs to agree to let you do it.
Exactly.
So, in the manuscript, you present a few different data visualizations that have used the tool. I'm wondering if you could turn them into words for our listeners. So, particularly figure one, can you walk us through that one?
Yeah, of course. So in figure one, we have a screenshot of the web based app showing a selected patient's disease trajectory across multiple organ systems. So at the top, we have information about when the patient developed scleroderma, their autoantibody results, and also their major disease manifestations. And you can scroll down and see medication history, such as when different immunosuppressive drugs were used, and then also the longitudinal data from selected organ systems. And it's hard to see in the figure, but user can hover over the points in the graph to see exact values of these measurements. So here we only have cardiac, pulmonary, and cutaneous measures for this display, but the users can also see trajectories in other organ systems, including gastrointestinal, renal, peripheral vascular, and muscle. They can also see relevant lab trends over time and patient reported outcomes like Scleroderma Health Assessment Questionnaire Disability Index. These data are real time and up to date for clinical use. So, importantly, we show a patient's trend over time relative to other scleroderma patients too, because we think learning from other patients' clinical course can help make better decisions.
Yeah, so let's talk about that some more. So you allow the clinicians and sitting beside them in the clinic, their patients, to look at trajectory against the whole scleroderma population and then also to filter it by specific reference populations. So perhaps a group of patients with similar antibody features or similar disease manifestations. You give us a visualization of that in figure 2. Can you describe that for our listeners?
Sure. An important feature of this tool is that it illustrates a patient's trajectory relative to a population that the clinicians can define using interactive filters. So, here in figure 2, it shows how the reference population could change the interpretation and perspective when assessing patients' disease state. On the top panel, this patient's lung trajectory is compared to the overall scleroderma center cohort. So you can see the three yellow lines in the background. They're the 10th median and the 90th percentile lines, summarizing the reference population's data. And on the bottom panel, that same patient's trajectory is compared with a reference population that is similar to the patient in terms of age at which they developed scleroderma, their cutaneous type, this person had diffuse scleroderma, and their autoantibody type. So, when comparing this patient to the overall scleroderma population, we observe that her forced vital capacity percent predicted declines from the 90th percentile to the 10th over 20 years of follow up, dropping rapidly below the 50th percentile line after 10 years. But relative to other similar patients who share her clinical characteristics, this reference population that's selected for this patient, we can see that her FVC trajectory is better than what is typically expected for the first 10 years of the follow up and around the median afterwards.
Amazing, actually. And you did a little bit of analysis of what the patients and their providers thought about these visualizations. You asked for input. What did they tell you?
So we got a lot of positive feedbacks from patients and rheumatologists. So the patients felt that the tool improved their understanding of their disease over time, and seeing the data for the reference population really gave them a sense of where they were on the spectrum of the disease. And they also expressed that they felt more confident and empowered in dealing with their scleroderma. Rheumatologists said that the tool saved some time, and we found that they were able to assess 9 times more data in 80% of the time using two-thirds fewer clicks when they were using the tool compared to the standard Epic workflows. They also reported that the tool enabled them to see new trends and patterns in a patient's disease that were previously hard to appreciate. So, as a result, they felt more confident in their medical decision making.
Yeah, it's kind of amazing. And I'm intrigued. What kind of training did you give the providers and the patients when they were looking at this data?
So we went over, especially for the rheumatologist, the general going over the tool and how to click on different things and how to visualize the data. It was the training that they went over. And also patients, it was more of showing them their data and actually showcasing the way of filtering the reference population so that they can actually see where their trajectories are in terms of their selected reference population was the training.
Yeah. So you present pretty detailed predictive and risk models in figures 4 and 5. So this would enable the physicians to estimate the likelihood that a patient would exceed a high risk threshold for a specific clinical parameter over a defined time period. Can you tell us a little bit about those models?
Sure. To predict these clinical events, we projected each individual's trajectory into the future by really harnessing the knowledge from that patient's prior trajectory and known outcomes from other patients with similar subgroup characteristics. And we then calculated the probability that the person will cross clinically meaningful thresholds for outcomes such as interstitial lung disease, pulmonary hypertension, and cardiomyopathy. And we projected these estimates 6 months, 12 months, 18 months, and 24 months into the future. And then we estimated the event probabilities using an algorithm we developed called CVSP. And what it does is that it just sequentially produces the risk of events as additional data observed in real time for a patient. And these predictions are made without having to refit a model every time a new observation becomes available, which would be very computationally heavy. And we use a cross-validation methods, so that enabled a real-time prediction.
Yeah, I really love it. I'm intrigued though. Were the patients able to see these models through their own portal? So were they looking at it on their own, or was this only in the context of a clinic visit where the provider could help answer their questions and perhaps alter those filters in ways that were accurate and meaningful and not going to scare someone?
Yeah, so in the study, patients were shown their own data over time relative to the reference population featured in the tool. And currently, doctors can show patients their own data in the tool in the context of a clinical visit and address any questions a patient may have. We are also conducting another study now to test the value of showing the predictive modeling to rheumatologists. For this study, patients are not participating, so they don't have access to the predictions yet.
I do think it's incredibly helpful, but definitely could imagine that context of use is really important and making sure that we are thoughtful about explaining what these tools mean is really critical. I'm intrigued also whether you're able to filter by medication use, both for a specific patient and then in the comparator cohort. So, can you consider a trajectory with and without a medication change for a specific patient?
I'm actually really glad you brought this point up. This is a really important point. And at the moment, we only display medication information descriptively, but our longer term goal is to actually generate possible disease trajectory with their uncertainty also under different treatment scenarios that could help inform clinical decision making. In collaboration with Dr. Yijin Xu at the University of Utah, who is a causal inference expert and a colleague of mine, we have developed methods that allowed us to simulate individual specific pulmonary and cutaneous trajectories with and without mycophenolate treatment. And that has been an important first step toward thinking about how treatment effects can be incorporated into patient level predictions. So, moving forward, we're really hoping to extend this work to a broader range of medication and more complex treatment regimes, including medication changes, dose escalation, combination therapy, or tapering. So ultimately, the goal would be to embed counterfactual trajectory predictions into the tool so that it can support shared decision making between patients and clinicians.
Yeah, I mean, I think it will be so valuable and incredibly useful for both the clinician and the patients to be thinking through what changes could be made to a person's clinical regimen and how that might impact disease down the road. I'm intrigued to know what other plans do you have to further develop this tool? Are you going to be validating it in other cohorts, testing it in other ways?
Yeah, so major goals for the future is the external validation of our predictive models and also dissemination of the tool. So we've already been able to reproduce our findings in the University of Pittsburgh Scleroderma cohort, which was an important early validation step. And going forward, we'd like to test the tool in additional external cohorts and better understand how it performs across different patient populations and care settings. And currently, we're also working through some of the practical barriers of doing this, of validating our results because of the data sharing restrictions and protocols. It's not always feasible to move patient level data across different institutions. And to address this, we are developing federated learning approaches that allows us to perform validation across sites without actually having to centralize or pooling the data. So we've been working closely with collaborators in the Johns Hopkins Biostatistics Department, including Dr. Jessie Tong and our PhD student Yi Cheng Shen on that effort. In parallel, we're also refining the model itself by incorporating additional clinical relevant variables and improving its predictive performance so that it could be as robust as possible and also generalizable in different populations.
Yeah, I mean, I think those plans are so important, and definitely the federated learning models are going to be the way to go, particularly with clinical data. In the Hopkins setting, are you using this tool actively in clinical practice, or is it just being used in the research setting?
The part of the tool that shows a patient's longitudinal data relative to a reference population is embedded in Epic, and our rheumatologists are using it in routine clinical practice. They've noticed that it generates a significant time savings, and it's a great way to show patients their data and explain certain medical decisions. Also, in our multidisciplinary long conferences, this visualization also helps the doctor to see the trends that were previously hard to appreciate. The prediction models are currently only available in a research context, and we're currently testing whether it enhancing the decision making.
Yeah, it's amazing. I'm going to take you on a different direction now. Wanted to explore a little bit about your career journey because I'm touched by the fact that you really have a background in computational biology, biostatistics, and yet you've sort of embedded yourself with rheumatologists. and I'm fascinated by this decision. So, what drew you into rheumatic disease as the canvas for your career? Did you just want to pick the most challenging area so that you'd always have something to work on? Or was there something that you used in terms of modeling and prediction that identified rheumatology as the field with the best opportunities?
So I think for any statistician, rheumatic diseases and scleroderma in particular are actually a very exciting area because I work in personalized medicine and these diseases are so complex and multi-system in nature. And to understand something as fundamental as a patient's lung function, for example, we often need to integrate information from many different sources: pulmonary function tests, chest CT imagings, echocardiograms, autoantibody profiles, and now we're also incorporating information from digital health data like home spirometry and step counts. So from a statistical perspective, that creates both a challenge and also a huge opportunity. And we're constantly thinking about how to combine diverse types of longitudinal data in a way that is clinically meaningful and can ultimately improve patient care. And another reason that the field was so appealing to me was that although scleroderma is a rare disease, we are very fortunate to have one of the largest and most deeply phenotyped research registries in the country. And this kind of rich data environment makes it possible to ask really important clinical questions and develop new methods that would be very difficult to study elsewhere.
I definitely think that's true, and you are in certainly one of the best centers for doing that. As someone who's really making your name in modeling and prediction for disease trajectories, are there other areas of rheumatologic care that you think are particularly promising for developing tools like this?
Yeah, so one of the things I find most exciting is that many of the approaches we developed in scleroderma are highly transferable. So methods for integrating multimodal data, modeling disease progression, and predicting clinical outcomes can be very often applied to a wide range of chronic multisystem conditions. And I see tremendous opportunities to expand these approaches in other rheumatic diseases, including rheumatoid arthritis, Sjogren's disease, and myositis, to name a few. And because these conditions are so complex, they involve heterogeneous disease processes and there are increasingly rich sources of longitudinal data. This makes them very well suited for predictive modeling.
I'm sort of struck by how well you were able to embed yourself within the rheumatology field and yet really do something that no rheumatologist could ever have conceived was possible. So, huge kudos to you. I'm wondering, now that you're established in your career, are there things that you look back on, moments or times where you agonized over decisions early in your career that you now kind of recognize more as predictors of success? Is there anything that you wish you could go back and tell your younger self?
So earlier in my career, I still consider myself being very early in my career, but I used to think that to do good research in medicine as a biostatistician, I needed to become an expert in almost every related field. I felt a constant pressure to acquire more disease specific knowledge, biology, study design, and the technical side of statistics all at once. And a lot of times I worried I was becoming a jack of all trades, master of none kind of person, especially because there was just never enough time to learn everything as deeply as I wanted to. And looking back, I think that kind of mindset actually reflected something useful, like curiosity and a genuine desire to understand the problems thoroughly. But over time, I realized that strong research is rarely done by one person who knows everything. So, what really matters is learning how to work with good collaborators and mentors who complement your expertise and help fill in your knowledge gaps. And that shift changed how I approach my work, and I became more comfortable asking questions, relying on my multidisciplinary teams, and focusing on contributing my own strength rather than trying to be the expert in every area. And if I could tell my younger self anything, then it'd be probably that good research is collaborative and part of becoming effective is recognizing where you can contribute and what you can learn from others.
Yeah, it's such good advice. I really appreciate you sharing it. Since you touched on mentors and you talked a little bit about your mentors earlier in this discussion, who were the mentors who were instrumental in your journey?
I've been very fortunate to learn from many senior researchers in the Johns Hopkins Rheumatology Division and also the Biostatistics Department. But Drs. Ami Shah and Scott Ziegler continue to be especially influential in shaping my academic career. I also feel very lucky to have mentors in the both worlds, medicine and biostatistics. And Ami has provided me with some of the most exciting research opportunities, and she continues to guide me through every stage of my development. And I've always admired her clinical knowledge and research intuition. Scott has been instrumental in building the statistical foundation I rely on today, and I continue to learn from his perspective, intuition, and rigor. Their mentorship shaped my technical skills, but more importantly, how I think about research, collaboration, and growth as an investigator.
Yeah, it's just amazing to hear your journey. And I'm kind of struck by the fact that you were able to bring together the biostatistics, mathematical modeling, the rheumatologists who are data heavy, but really very hands on, and help them kind of work together without being afraid of each other. So it's really amazing to see what you've done. Do you have any tips for other modelers and biostatisticians out there who may be earlier in their journey than you, and what could help them predict a successful career trajectory?
I'm really still learning myself, but I think it's important for biostatisticians in medicine, especially, to learn how to speak the language of both worlds, translating the complex analysis into a clinically meaningful context and communicating these results in a way that clinicians can easily interpret, appreciate, and apply is a crucial task for us biostatisticians.
I completely agree. And I'm wondering, at what point are you going to be developing the R Shiny app for, helping people pick which disease area should I study?
Maybe in the near future.
I really want to thank you, Jisoo, for all of your insights today, for sharing your work on scleroderma, and for sharing all of your expertise and experience throughout your career journey.
Thank you so much for having me. I really enjoyed sharing my research, and I really appreciate being invited to the podcast. Thanks, Vicky.
So as we wrap up, I also want to offer my thanks to all the other rheumatology-focused biostatisticians and computational biologists who take the noise of our clinical data and reveal patterns that change how we diagnose, treat, and understand complex diseases. Your work turns data into improvements in care, and we're so grateful for the clarity that you bring and the possibilities that you reveal. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Rheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.